as Raphael said, I have a bunch of different titles here, and part of the reason that I have that is that I work with different communities and different audiences. So when I began my career, I am a cancer researcher, and much of what I do is looking at patients in the context of their communities and how they access health care. So I work in the area of cancer survivorship. My research is focused on preventive services delivery. I have a particular interest in working with vulnerable populations and looking at how they access and what are the issues and the barriers that they have as they move through the system. And the research methods that I use are really around implementation. So how do you get from point A to point B? What are the issues? How do we address them? How do we do user-centered design, and how do we think about our systems in ways that we can help our community members access services, as we heard from Ketlin's really lovely talk right before us, into moving into the health system. So what Raphael asked me to do is two things today. One is to introduce myself, talk a little bit about my science and the work that I do, and then also to talk about some of the resources that we have here. So I'm going to be focusing on the work that I do with the New Jersey Alliance for Clinical and Translational Science, or our CTSA. So the CTSA actually is a really large award that we have for clinical infrastructure. It is a $47 million grant. We got our first one 5 years ago. We just got the renewal this past May, and so we actually are celebrating sort of the beginning of the next 7 years of our iteration. I really got my introduction to community-based or community participatory research as part of this particular endeavor, because during COVID, we had a supplement to the CTSA to get the word out about the importance of COVID testing into our communities. And so I'm not going to do a deep dive into the study, but I wanted to just tell you a little bit about HEROES and how that informs the work that I currently do and as we move forward. So the New Jersey HEROES Project was a study that looked at outreach, community outreach, and look to see what are the best ways to get messages out during a health crisis to communities in need. And so in that particular study, we focused on the populations in most need here in New Jersey. In particular, it was Essex County, Union, Middlesex, and Passaic counties that we were focused on. And we were looking at it because we saw that there was a lot of higher rates of death, higher rates of COVID, higher rates of social vulnerability, and wanted to make sure we were concentrating our efforts in those spaces. So we partnered with 22 different organizations to actually test what are the best ways to both design materials, to actually get out into the community, and then to really get people through the process of testing. So one of the things that we did in this particular study is we were really focused on thinking about how do you build trusted relationships with the community. As you saw in the previous slide, there were 5 of us who were actually working together as a team to do the science behind this, and Diane Hill, who is actually a vice chancellor here at Rutgers Newark, has a framework for thinking about how you actually engage with the community. And it's really focused on building trust, leveraging our resources and existing opportunities, promoting sustainable relationships, so making sure that you're not just dropping into the community, but that you actually have staying power, that you're acknowledging and embracing all of the different perspectives that are in play and at the table, and that you bring people together and that you actually make sure that you resource the effort. So for us in that particular study, there were 4 sort of major areas that we really wanted to move forward. We started out with, as we put the grant together, looking at sort of what is the shared vision for this. So it wasn't just the academics saying we're going to do this, but us really talking about how do we do this, how do we do this together, and how do we actually make this move forward. Our study was an educational intervention, so a lot of the work that we did was around what are the right ways to get education out into the community, and also to think about what are the different modalities that we might need to address. So some organizations work with social media, other organizations were going out to people's homes and Meals on Wheels. We had door hangers, we had a bunch of different things, and we also had a lot of different populations that we were working with. So we had social service organizations, we had faith-based organizations, we had organizations that were focused around disease states. All of those different perspectives and all of those different groups really at the table, helping us to review how we designed our flyers, what we did, and we spent much of our time in sort of a continuous feedback cycle. So as we would get information, we would feed that back, we would talk with them on a weekly basis about what was going on, and most importantly, we worked with them to both interpret the data, but also to put out the publications on the study. So I think, with the HEROES team, one of the major things that we thought was really important was that we recognized the importance of bringing in the community in terms of our community-based organizations and the strengths that they had, and also partnering with healthcare organizations and bringing all to the table. One of the major things that we did also, and again, this goes back to Denise's slide, is making sure that the majority of our funding was actually going out into the community and actually furthering the goals of the different organizations that we were working with. We also, really important to co-create. So again, it's not really about do you take an agenda and shove it down someone else's throat, but really to think about how do you work together, have conversation, and then figure out what is the best way to negotiate conversations around things, and then regularly sharing our results. So HEROES is really I would say the foundation to my current research portfolio, because now post-COVID, I have a number of different initiatives that I'm working with in terms of thinking about how do we move back into the healthcare system and address sort of the population health needs within our healthcare settings. So for those of you who are interested in seeing more about my work, you're welcome to click on the QR code and it will take you to some of our funded work. And right now we've got 4 different projects that are currently in the field. So we have one on breast cancer follow-up care that's looking at the impact of implementing evidence-based guidelines within primary care settings. I have another study that's looking at follow-up colposcopy and how do we get women who are at risk for cervical cancer and advanced cervical cancer diagnosis into early intervention with colposcopy screening. Also looking at a care coordination intervention around complex cancer survivors. And then I'm also working with Dr. Ethan Holm, who's here, on a learning health systems science initiative that trains scholars to think about how do you do rapid cycle research within healthcare settings to actually think about quality and safety and move what we're finding very quickly as problems into solution or problem-solving mode. So that's sort of who I am and why I'm on the panel. And really quickly, I just want to talk about one of the resources that's available. So I serve as the Associate Director for the Community Engagement Core for NJACS, which I introduced before. There are 3 other co-leads, so Diane Hill, who was on the slide at the beginning, as well as Manny Jimenez, and Dr. Alfred Talia. And so the 3 of them lead a core that has at its core I like to read the blue pieces as opposed to all of the black language. The black language is our academic speak. So we have 3 major goals. The first one is to bring novel learnings from what we understand here locally to the broader CTSA consortium. So there's 60 CTSAs across the country, and we are the only one in New Jersey. Our second goal is to empower community members to engage with translational research. So we provide resources to help with that, and I'll show you a couple of them. And then our third goal is really to teach researchers how to talk about their science in ways that actually makes it relevant and interesting to the potential communities that they either want to engage or to inform or to work with in terms of policy. So we have an engagement core group that works with us, partners, and so some of it is composed of members who are actually part of our supplement, the study that I just talked about. We also have added SPAN New Jersey and as well NJ Lind as representatives to the board, and they really come together to help us to understand sort of what are the issues in the broader New Jersey community that we should be tackling from a translational science perspective, but also importantly, they help us as either community groups come in looking for academics to help think about who are the folks that we work with that could be partnered, and on the other side for academics who are looking to partner with community groups to help us think about who we should work with and how do we help that happen. So we actually serve as a matchmaking service in many, many ways. We offer consultations that are one-on-one. We have virtual engagement salons, which allow you to have a group of people sort of kick the tires around concepts. And again, we invite people who are interested either from a community perspective, we can hook you up with researchers, or vice versa, researchers who are looking to work with community groups. In addition, we have a pilot program that provides funding and a community scientist program for individuals who are interested in learning more, who are community members, about the research process and being engaged and then partnered with researchers. That is a vehicle as well. So those are the major resources that we have within the CTSA, and I am very excited to be part of this panel, and I'm going to stop talking so the rest of us can actually get to what we want to do, which is talk. So thank you.
Rogers, in your body of work, thank you for opening up with that candor of the current environment that we are in. We cannot move forward without acknowledging the reality of the atmosphere in which we exist, in the milieu, and the impact of that it has on us as people. We are people in this room together seeking to impact the human condition. And so it is refreshing to see a room that represents community in earnest as I look out across each one of you, the diversity in the room. That represents the community, and in my discipline and in my values, what represents the kingdom in which we are seeking to impact. So thank you for that, and thank you for this space. And I just want to encourage you, before I tell you a little bit more about who I am and my body of work, that in this room there is hope, that in this room there is courage, that in this room there is impact. And in this room, there is that which is going to move us forward to the place in which we are all seen as assets. And so please be encouraged, and thank you for setting this encouraging space. So I am the Chief Visionary Officer and founder of the Commonwealth Center for Fathers and Families. As you in the public health arena look at the SDOHs, I want you to ask your question, or I'll pose these letters to you. WTF, and I know that's in, y'all's minds are in the gutter. WTF stands for Where's the Father? Where is the Father? You cannot, I don't know if there's any Maslins in the room, but there likely are, because it was a foundational component of our bodies of work that we do in the academy. I don't have any slides, by the way. I'm not with the academy. I don't get nervous without slides. I actually am that guy that makes the academy nervous. And so, because I'm from the community, right? And this is the body of work that you want to do and you seek to do. But if you look, you could not look at Maslow's hierarchy of needs or even those 5 social determinants of health without looking at each one of those levels or each one of those determinants and not somehow draw some correlation between that and father absence, not just quantitatively, but also not just qualitatively, but also quantitatively and empirically. What we know is that father absence is either correlated or perhaps even has causation of all of those issues and pathogens that we seek to address as providers and researchers and academicians and others that do this body of work. If you go throughout Newark, if you go throughout this great state, you will find that all of the issues you're seeking to address, that you could identify some metric that's associated with father absence, from early childhood development and even prior to that, prenatal health and maternal morbidity and childhood morbidity and postpartum depression. Fatherhood is inextricably tied to maternal health. If we go to education, we know that fatherhood is tied with educational outcomes. Not only are students more likely to do better in school academically, but behaviorally is also. Mental health is inextricably tied to father absence, crime and violence, substance use disorder, and any other issue that you're seeking to address, we have found that father absence can be associated with. So that's my drum that I beat, the fatherhood component. We do so at the Commonwealth Center for Fathers and Families. We address this issue with less than a direct service delivery approach, but rather we seek to affect systems of delivery, pedagogies, and paradigms and get them to ask, WTF, where's the father? We even believe that the business arena should be asking that question because we see economic impact of father absence. And so I really stand before you more as a practice of promise and a case study in which we see academy and community working together, and I stand here in context of fatherhood. And so the Commonwealth Center for Fathers and Families serves Kentucky, yet I stand before you with teeth and shoes. I know y'all's perception of Kentucky. It has its issues, but we do wear shoes in Kentucky. We do have dental care plans, and we are doing some forward-thinking, paradigm-shifting work. And we believe this work that we're doing at the Commonwealth Center for Fathers and Families does that because we do, again, less than direct service delivery to fathers, though I really come out of direct service delivery. And I come out of community organization. I would submit to you that anyone in public health should also be a community organizer, because I believe public health is really the intersection of psychology and medicine and sociology, and community organizing is an element that I believe has really fortified my work in all that I've done. And so if you have a chance to take, I'm talking about a community organizing track in earnest, I would encourage you to do it, for it's my time in community organizing that helped me forge any good works that we're doing. But we work with systems primarily. We work with our service delivery systems across sectors, again, because of the breadth and depth of father absence and all the indicators that it actually is associated with. And we seek to impact policy, practices, and procedures so that they are more father-centric, so that fathers and men are responsibly involved in the lives of children. Expanding that, I had the opportunity to be a part of a project that was with Dr. Raphael and another one of our colleagues, Dr. Antonio Garcia, both at the time at the University of Kentucky, in the School of Public Health and the School of Social Work, respectively. At that time, there was a wonderful program headed by Robert Wood Johnson Foundation, the Interdisciplinary Research Leadership Fellowship that some of you have heard about. You will hear from a brilliant progenitor and contributor to that project at our keynote. But I will tell you that that project allowed me to be part of an exercise that I think absolutely exemplifies this principle of community and academy and the absolute, what I believe should be a mandate for that to be the methodology and the template that we use to find solutions for our communities. Because regardless of what we see on a global, a universal, global, international, and national level, it's just as they say of that P word, politics, that you mentioned is unavoidably part of what we do. It's all local. I believe the solutions are all local and at that community level. And so if you do not have community involved in the body of work, it's like finding a cure with no method by which to administer the cure. It's as if you found the cure to cancer, but you don't have any way to administer that medicinal that cure to the individual with cancer. It's useless. And so this project brought us together, and the academicians, not unlike your model, right? The academicians had to choose a community partner, and that was me. And so I was the adjutant in this project for 3 years in many ways because the community that I worked with in our population, our study was around fatherhood and the efficacy of a curriculum, but moreover, it was about principles and approaches that involved community. And so here are some things I would say to you that I found valuable and found to be most important as we were in this exercise that was through Robert Wood Johnson, but we activated in the community of Lexington, Kentucky. First of all, both these doctors and these individuals from the academy immediately established, and we actually wrote together agreements, and we wrote and signed and covenanted together in agreement that we were on a linear ground, that we were all equal. That sounds simple, but we'll never see people as assets until we first see them as equals. You will never see people as assets until we first see them as equals. And so we established that, but it was not just in writ and word, it was also in action, and that manifested in many ways. It manifested in how we published work. So if they published an article with their doctors in front of their names and their commas and letters behind their names, there was also David Cozart. And so I'm now a published author in several different places, and I didn't have to go to school for 8 years, right? I'm the smartest one on the team. That's more than just symbolic. It actually acknowledges what I now know, and not to sound precocious, but the knowledge and lived experience of those in your community, degreed or not, is as important, if not more important, than the knowledge that you have from your academic pursuits. And you have to acknowledge, you have to do that and express that in an animate way. And when I get to be published in articles and be a beneficiary of the arduous task of doing that, that is one such way. You're validating to the community that you're authentically working with them and valuing what they bring. Again, I know that what the community brings is as valuable, if not more valuable, than what others bring. But that's one way it manifested. The other thing is the work was not situational, circumstantial, or around this exercise or research. And so they did not have, nor would I allow them to have, the community of service or my community in the laboratory for the period of time within the parameters of the project. I'm a Baptist minister, so alliterations just kind of come out. I didn't even know that was going to happen, so I'm sorry about that. It extends beyond the project. And that was proven and is still proven today in that I do work with Dr. Raphael and Dr. Antonio. We presented at the American Public Health Association International Conference, and we also present together at the Social Work Research Conference, and we continue to do the work. And so I would end my comments in time by saying to you this: if you are genuinely interested in doing community engaged work, you need to find that it's not rocket science. You need to find that ambassador within the community. You need to have under your belt some of those community organizing principles, and whatever you decide to institute, it doesn't need to be situational. It needs to be longitudinal. I could speak on and on and on about the processes that we went through and continue to go through that validates this work. When I'm working with African American fathers, I did want to make sure of this. There are challenges to that. If we're looking at marginalized communities, and I know that's one of the words on the list of prohibited words that we're all being put before us, but working with fathers, particularly African American fathers, there are challenges to that really, I believe, supersede many other populations, and it really has to do with those compounded issues that you know that they would deal with based on the disproportionality of so many other in areas such as incarceration and health disparities and educational disparities and workforce disparities. And so that is a challenge that I deal with in working with fathers. And so even in this research project, as we looked at the dissemination, here's another component in which I really appreciated your work, sister, is that the dissemination of our research, and I would offer the dissemination of your research, should be absolutely tailored to certain populations that you want to uplift. And so because we knew we were looking at African American fathers or marginalized fathers, we disseminated in ways and in spaces and in modalities that we felt would resonate with them. And so our findings from our research, we had spoken word artists to look at the research, put together pieces of spoken word that articulated the research. The advisory group, and Dr. Raphael and Dr. Garcia and myself looked at that to make certain it was congruent with our research findings. So we distributed in spoken words. We even distributed that in poems. And I was appreciative of the Maya Angelou reference earlier, and I told Dr. Rogers she had that spoken word melodic sort of cadence as she read that, so I appreciated that. We distributed our findings, the dissemination in spoken word. We also had a local hip hop artist to put together a piece around our findings and use that as a dissemination product. And lastly, we did some of the traditional ways, many graphs, many charts, also articles, academic articles and in journals and things of that nature. I'm still getting emails from them of stuff they need from me to get it in an academic journal. It takes y'all an act of Congress to publish something, and so I'm glad I don't have to go through that process, but we did use those traditional means as well. Again, I am absolutely appreciative of the space and the sentiment in the space. And again, in this room is hope. In this room is encouragement, and in this room it's the opportunity, and I believe actually in this room is impact, even in such a time as this. So thank you all, and I'll have my seat.
I just want to say there's a lot of people in this room I admire. I'm going to try not to point you out because, I don't want to leave anyone out. But I've learned a lot working in Newark and the population that I work with. I think the city of Newark for me has been a true community. I've worked in Brooklyn and Queens and Manhattan and many different areas and many different type of populations. But Newark was a population that welcomed, needed help, maybe didn't always know how to ask for it. But I love what Caitlin said, there's a culture. We all have a culture. And if you respect the culture and you let that culture grow and be who they are, they will come and they will correct and help their own community the way they need to, not the way we need it. And I think that's one of the big things to say today, which is we started as an HIV/AIDS organization, and that is our foundation, but I find us today to be far from that. It's truly the community health organization. And when I say community, I really mean community and the services behind that. And almost secondary, the health. Because if we don't have the connection and the thought of our community, we won't get anyone into health. So as I say here, our mission is to empower our clients to reduce social and health equities in Greater Newark and surrounding. I want to take a second to just talk about myself and how I got into this. As a white man sitting up here, and we talked a little bit about race, I want to talk about that. My background, though, is I'm a social worker. That's my education. But I was also raised with a learning disability and a recovering addict for 37 years. So when people looked at me as a kid, as an adult, they see the white man about walking in a room and passing. I was roasted many years ago at a birthday. And one of the things they roasted is, Brian desires to walk in do not enter signs. But that's my privilege, right? I walk in, I don't think about it, and I want to go and explore something I'm supposed to not. And I see some of my friends that struggle with that. My partner, who's Latino, would not do that. He plays by the rules. Brian, I'll take that extra step. Why? Because I can, as that white man. My learning disability. People saw me as a white kid, played sports, so on and so forth. That's what they saw. They didn't know what I had. I'm also a gay man. They didn't see that. They just saw this white kid, this white man, who was able to do things that maybe not everyone could. Not because I was better, but because of my own privilege. So I just want to bring that up because I think that's a lot of what we're going to be talking about as we go forward. Politics is part of that. So just to understand, when I work with my community, I try to think of some of my strengths and weaknesses that others may not see. Not about what I look like, but about that learning disability, about being the gay man, about being the recovering addict. Because those are not weaknesses, those are my strengths. And I see that so much in my clients and so much in the people I serve and my staff. We're all individuals and we're all unique. I know there's a lot of people from academia here, and we may have gotten into what we did, as I did social work, because of an interest in our work. But underneath it all, there's something else that brought us there, and that's what brought me. So now I'm going to get into a little bit of NJCRI and how NJCRI became, because I feel like it's its own personality and its own growth. So real quick, the early days of NJCRI was created as an HIV AIDS organization around research and clinical trials. Why? Because clinical trials was being done in New York, not in New Jersey in the same robust. So the early days, if we think of COVID more recently, there weren't a lot of drugs that were approved yet. What we could do, NJCRI becoming this small community-based research group, we could actually provide new state-of-the-art drugs for HIV/AIDS to let them know what's going on. And therefore, we were able to give those drugs right to our people without barriers of healthcare. From there, we moved into the HIV services that we were able to do and the clinical trials we were able to do to start piloting behavioral and social health programs from YMSM, our Project WOW, which is 25-year-old LGBT youth center, to prevention with positives. We think of prevention, today we think of prevention with prophylactics for HIV negative, but we also look in the earlier days about how do we keep people with the virus educated and keeping barriers so they didn't pass on. Many of our pilots were also not done by government, but done by foundations, and I see Healthcare Foundation in the room, and thank you. We had foundations that would believe in us and give us that little seed money to start the work we did. And by doing that work, we were able to show the competency and the need for such services. So with that, when we started with a small foundation, it just helped us be able to develop and then move into more sustainable funding, such as government and such. In today's area, we're in a place of, I think, thriving as an organization and as in healthcare. What got us here? For NJCRI, I think one of the things that we knew we were infectious disease as much as HIV. We were community service as much as HIV. And we were meeting the people on the streets as much as what we've always been known for, HIV. So when COVID came around, we were able to see it's similar to an infectious disease of blood, airborne, mask instead of a condom, vaccine instead of an HIV drug. And with that concept, we were able to help move forward and help our community. Our focus was not the general population that came in to get their vaccine or get tested. Our population was the homeless. Our population was the hard to reach. Our population was barriers of language. Our population was the undocumented. The people that met, we met a lot of our people 5 a.m. at Home Depot or Penn Station. So that's something that I think what we've done over the years is adapted to who we are, adapted to our community, the crisis of HIV, the crisis of COVID. We're also working on something around Hep C, mobile medical, not more than just Hep C, but also other mobile medical units that we do, where we do care on the street. I know that's something that's starting to evolve. I think Rutgers is doing it and Robert Wood. But this is something that we've done for a long time. We were in Patterson not too long ago in a train station. We had health screeners, behavioral health workers, medical care, Hep C, test and treat, going back with telemedicine to go back to the street. We have a pharmacy that will meet the patient if they live on that train track at that train track. So that teamwork and the creativity where I let go and I just find out we went where, because it's not me anymore. It's the staff that bring this together and their creativity. Where are we going? 2025. So I keep using the conversation about a roller coaster, right? We don't know. And that's one of the things I think where we're at next, is that we're not sure where we're going to go. But with our own collaboratives and our own support, thank you, we've done a lot with research, learning new things, foundation, getting that support for those new pilot programs, and government that helps us sustain that longevity of our work. This real quick, I'm just going to run through. These are just some of the services we built to show that we're more than just HIV services, that we really are more diverse. So that was medical. This is some of our behavioral, from psychiatry to MAT programs to research and clinical trials, which is really a backbone that really teaches us where to go next. Our homeless services and our youth services are LGBT, other, very strong in the community. Our homeless service serves, I can't tell you, about 165 people a day, about 200 people at a food pantry line, housing, mental health, substance use, all the above. This is where we want to get, and I felt like we were going there, and we have to stay there. How do we stay servicing our people? And our doctors and our nurses are the end route to help our patients, but we, a lot of our case managers, our social workers, need to start that direction. You know, we now have terms called community navigator, community outreach worker. These are important titles, as I hearing from some of our staff that are moving in those directions, and I think this is where we need to go going forward. So just want to say thank you, and see you later.
Thank you so much, Brian, and thank you to all our speakers. So we have like some room to let you ask a couple of questions. I would like to start with one question for our panelists. And when I listen to your presentation, something that I think in common is like when you're talking, David, I think about like mass incarceration and racism and discrimination and many other issues that limit the work that we do. I wonder, like, to what extent do you address that in your work, and how, like, community engagement can help us mitigating those barriers that we face in advancing health?
So I think for me and our team, I think community engagement has been the biggest pathway to our success. I think hiring people that know our community, that are cultural competent to our community, that understand the goals of the healthcare of our community, of what we're trying to get to. So it's not only the community side, but the healthcare side, and understanding both. I think that working with the research end, we have a lot of people that on our behavioral end, we're actually just looking at moving one of our centers, and we're trying to bring research in to be able to do some of that assessment. So being able to look at our community and how do we assess that. I'm going to pass.
Thank you for the question, Rafael. And so I would say that in terms of the academic mission and partnering with it, we want to make sure that we're addressing the questions that are actually relevant to the community. So we really need to partner with community to better understand what those issues are. I think oftentimes, we privilege within the academy bringing in academics who have a particular prestige or a niche area, and we don't really think about how do we actually harness that expertise in a way that actually works with the agenda. So particularly for the CTSA, which I represent here, we really are tasked with addressing the disparities, needs of the state. And so for us, being in touch with what those issues are and who are the people that we can work with is really important, because it's not helpful if you're working on something that is not actually going to really address the needs within the setting. So.
Yeah, I didn't know if you wanted each to address it. I would just say that if you don't have community engagement, you're wasting time, money, and resources, quite candidly. I heard one of the barriers you talked about, or one of the issues you mentioned in your list, was mass incarceration. If you seek to address that issue without having some lived experience, returning citizens, even at the level of method development, research development, then you are potentially wasting time, effort, and resources. And the community or the population in which you seek to bring healing, you are like a surgeon that is performing surgery with an infected scalpel. Where you seek to bring healing, you could actually bring infection. And so I would ask that, I would venture to say that you're wasting your resources if you don't have community engagement of the population you're seeking to serve.
Thank you so much. Any questions from the audience? Her question is like, if you can give an example, is this toward David? David, if you can give some examples of the systems with which you work at the Commonwealth Center for Fathers and Families.
Yeah, the systems in which I work or work alongside or seek to impact healthcare, right? I want that WTF question in OBGYNs, in prenatal care, even preconception. Other sectors, certainly justice, because the disproportionality of father-centric services and decisions in family courts when it relates to custody. We work with legal systems in jails, prisons, the Department of Corrections. Our major partner is our state-level cabinet for health and family services. So I think it's called Community Family Services, maybe here in New York, or Family Services, obviously because of father engagement and its reduction of child maltreatment. We're venturing into our Attorney General's office, unlikely place, but in Kentucky, our Attorney General seeks to address substance use disorder, but also human trafficking. Father inclusion and fathers are a major protective factor as it relates to human trafficking, which is a gigantic issue, yes, in Kentucky and other places. So again, I'm quite biased, but I don't know any sector or any system that would not benefit from examining ways in which they could seek to have father-centric services in their methodologies.
Thank you so much, and I will ask you to give a round of applause to our first panel.